Today I presented some in vitro and in vivo data which we developed in the lab about a novel therapeutic drug which is called AZD8055 to inhibit the mTOR, the kinase catalytic domain, and therefore inhibiting the both complexes of mTOR, mTORC1 and mTORC2. And we think that's superior to the previous inhibitors such as rapamycin or the analogs of rapamycin called rapalogs, which inhibit only the mTORC1 complex, then leaving the mTORC2 free and released from the negative feedback loop of mTORC1, therefore then signaling and pushing the cells into cell proliferation and survival. First of all, in the poor prognostic patients, 17p deleted and 11q deleted patients, cells from the peripheral blood, some of the targets of mTORC1, such as phosphoinositide, they were lower, and also phosphoryctor, which is also a target of mTORC1, it was lower. Well, that was a nice reflection of both proteins. But crucially, the phospho-AKT, which is we think is a crucial factor for survival in CLL cells, was sustained in 17p and 11q. And when we treat the cells in vitro, there was a significant reduction in cell viability with this drug. But this inhibition of viability was lost when we use models to mimic the microenvironment in the lymphoid organs, which we call CD40 ligand, IL-4, or BCR. We lose the cell viability effect, the reduction effect of the drug. So we also looked at signaling pathways through Western blot analysis, so looking at protein levels, and we saw the drug hit the targets, all the mTORC1 and mTORC2 targets as it should, so it's working fine in that point of view. But it's actually, we had a look at a key factor, survival factor for CLL, which is called MCL1, which is a member of the BCL2 family and is a pro-survival factor. It's been associated with CLL resistance, drug resistance, and in clinical trials. And we saw that this drug doesn't particularly target very well in this CD40 microenvironment, doesn't target MCL1 at all. But on the other hand, when we stimulate the cells with a different microenvironmental signal, which is called BCR engagement through IgM stimulation, we saw there was a cell viability reduction with the drug. And when we look at the Western blotting, so the cell signaling, we saw the targets were still hit as they should. And more importantly, MCL1 was inhibited, so there was much lower levels of MCL1 in the treated cohort than in the untreated cells. And so we have this type of indirect evidence showing that we think that MCL1 inhibition is crucial when we look at microenvironmental interactions for the cells to respond to this drug.
And do you think that this might lead to the development of novel therapies?
Yes, in fact, this particular drug, AZD8055, is not going to make it to clinical practice or clinical investigation because it's been refined, as you wish, as a molecule by AstraZeneca through a different second generation, which is called AZD2014, which is currently used phase 1 in solid tumors. And we suspect it will be just a matter of time will be tried in leukemias and CLL particularly, which is a good candidate because we saw, and I show in the talk as well by our data, that mTOR signaling is dysregulated in CLL compared to normal cells. The message would be that although we heard a lot of, also in this meeting, about PI3 kinase inhibition and BTK inhibition, which are very through drugs such as idelalisib and ibrutinib, which has been very successful. But we are already seeing reports showing early drug-resistant development from a few patients, but still they're already developing resistance after 2 to 3 year follow-ups. And we think it's just a matter of time this patient might develop resistance. There will be more patients develop resistance to this novel drug. So we believe that the dual inhibition of mTOR is a good alternative as a single agent perhaps, but more importantly in combination to give an extra options for these unfavorable prognostic patients. We don't have only an in vitro study about this type of drugs. We also have tested the efficacy of this drug is in vivo environment in actually a CLL-like mouse model, which replicates a poor prognostic subset, which we're talking about 11q and 17p deleted patients. And in this mouse model, we have a dramatic decrease of tumor burden in the lymphoid organs, bone marrow, spleen, lymph nodes, and blood, compared to untreated. So we think that this is, we don't have just the proof from in vitro, but also from the in vivo studies, which are more close, if you wish, to the human body. Although it's still a murine model, but it's much a closer step to a clinical stage for these drugs.